Um, I'm Ritesh. I'm presenting on behalf of Medicine 3. My title is Ahem. Uh, Presenting a 29-year-old a female Labrador Paragon living one, 27 plus 2 weeks of gestation. She came with complaints of fever and cough since past 2 weeks. Cough was non-productive. Fever was with high grade nodules and rigor. She was treated outside initially conservatively with paracetamol. Later, then in view of fever not subsiding, she was given oral antibiotics followed by IV antibiotics. In view of non-improvement, she was referred to CMC for further management. Outside ultrasound had revealed mild right-sided pleural effusion and subdiaphragmatic collection. Her antenatal risk factors were anemia, intrauterine growth restriction, and RH negative previous pregnancy. There was no history of loss of weight, loss of appetite, no chest pain, no palpitations, no syncope, no abdominal pain, no leg pains, no vomiting, no recent travel, no bleeding manifestation, no joint pain, no rash, no photosensitivity, and no one else in the family was sick either. On examination, she was seated comfortably. She was not in distress. She was tachycardic, but her pulses were regular, and all peripheral pulses were palpable. She was hemodynamically stable. She was mildly tachypneic and tachycardic. She had pallor and bilateral pitting pedal edema up to the ankle. There was no ictus, sinuses clubbing, or lymphadenopathy. GVP was not elevated. There was no rash or nashkar. On respiratory system examinations, bilateral breath sounds were heard, but there was decreased breath sounds on the right infrascapular area, infraaxillary area, and there was dullness and percussion on the right infrascapular area, with bronchial breath sounds being heard on the right infraaxillary area. Infrascapular area. There was no intercostal tenderness. Her cardiac examination was normal. There were no murmurs heard. Her abdominal examination revealed a soft uterus of 26 weeks, no hepatosplenomegaly. Her CNS examination was normal, conscious oriented, time patient person. Clinical syndrome wise, so 29-year-old with G2P1L1 with prolonged fever and cough, respiratory examination revealing right sided bronchial breath sound with decreased air intake. Differentials of time carrier differentials considered at this point of time was community acquired pneumonia, tuberculosis, lung abscess, aspergillosis. In her case, we had done an X-ray, which X-ray revealed a right-sided middle lobe consolidation. Her total counts were 12,500 with an 82% neutrophil predominance. Blood culture had showed no growth. LFT showed mild hypovolemia and a mildly elevated ALP. RFT was normal. Echo was normal. She had an anemia of 9.6. CRP was mildly elevated. Her bedside ultrasound, however, did not reveal any significant pleural effusion on the right side, which we were able to tap. However, in view of the fact that she was having recurrent fevers, we went ahead and did a HRCT. HRCT revealed a dense consolidation of the right middle lobe with a bulging fissure and a few hypodense areas. She also had few subcarinal and paratracheal nodes. Her sputum, initially she was not able to produce sputum. Her sputum by that time had revealed the fact that she had her expert TB was positive, had detected rifampicin sensitive MTB. So we will just quickly go through TB in pregnancy. So effects of TB tuberculosis in pregnancy. Active tuberculosis in pregnancy is associated with a greater mortality, and 50% of the people who higher mortality rate or also had a high HIV co-infection. Anemia was 4 times more likely. Antenatal admission was 9 times higher, and C-sections were twice likely. Miscarriages were 9 times higher. Risk of an untreated active TB was on the pregnant woman, and the fetus is much greater than the risk of treating the same. This is based on the study 2017 systematic review and meta-analysis done of 13 studies. This is a data from it's an old data from our Indian collection, which clearly shows that active TB in pregnancy has worse outcomes of fetal distress, premature delivery, small gestational age, low birth weight, and perinatal death. So treatment of tuberculosis in pregnancy was HRZD, all category were see drugs in as per FDA. As per US guidelines, pyrazinamide is a controversially used drug, but as per Indian guidelines, we continue. There is no contraindication. We give ATTs initiated. We continue to all 4 drugs can be given. ATTs initiated in the first trimester. There is a benefit more than initiating it in second or third trimester. Hepatotoxicity with isoniazid might occur more frequently in pregnancy and in early postpartum period. Streptomycin, capreomycin, kanamycin, ethionamide, and prothionamide are not to be used in pregnancy. So, in drug-sensitive tuberculosis, as per our Indian this thing, standard regimen can be followed up, monthly clinical follow-up with a laboratory follow-up at end of intensive and continuation phase. USG can be done at 18 to 22 weeks of pregnancy to diagnose any congenital anomalies. There's an additional requirement of 350 kilocalories of energy and 23 grams of protein. As we know, there is a Nikshay Poshan Yojana, which is a extra additional incentive for people who have TB. Throughout the per month, they'll be receiving it throughout the course of their treatment of TB. Undernutrition in patients with active TB is associated with 2 to 4 fold increase in mortality and 5-fold risk for drug-induced hepatotoxicity. In case of drug-resistant TB, our recommendations currently stand in the fact that if it is lesser than 20 weeks, we should recommend for a medical termination of pregnancy. But if the patient is unwilling, we'll have to go ahead with explaining the risks, or about 20 weeks, we have to explain the risks and go for a longer regimen and explain the risks to the mother and the fetus. Postpartum and in lactation, breastfeeding, the first-line TB drugs can be given. The concentrations are very minimal and cannot cause any toxicity. Isoniazid prophylaxis should be given to the newborn after rolling out neonatal TB. BCG vaccine also can be given. In case of every antenatal visit, we can quickly do a questionnaire of cough for more than 2 weeks, fever for more than 2 weeks, inadequate weight gain or weight loss in the past 3 months, any night sweats, and in case of any new lumps in the body. The factors affecting the outcomes of TB and pregnancy are environmental factors such as air pollution, social factors being poverty, malnutrition, gender factors being higher chances of being malnourished, lower access to healthcare, clinical factors being underweight and reduced immunity. In our patient, initially she was started on empiric antibiotics because she was treated outside and she came with high grade fever. But once the blood culture was negative, the antibiotic was stopped. And after initiation of ATT, she's been afebrile for the past 48 hours with no other complications. So take-home points being TB in pregnancy, there's a benefit more than risk always. First-line ATT can be initiated if sensitive and is safe during breastfeeding. Careful observation and review to look for evidence of hepatitis because they are more prone, and need for appropriate nutrition and excess requirements have to be met while initiating ATT.
Don't put investigations in your history because you put some ultrasound showing subdiaphragmatic collection.
Outside report.
Don't put that. It's not necessary. I think differentials also can be little better, no? Like aspergillus and all. Now it sounds like we did CT to diagnose TB, which we could have avoided because induced sputum we didn't wait for, or like that.
There was high grade spikes of fever and there was not, we couldn't tap based on the bedside ultrasound. That is the only reason for going ahead with the HRCT.
Induced sputum was sent before doing the
CT. Asked her, but she was not producing.
So finally that rifampicin expert came positive in what sample?
Sputum itself.
Any doubt?
If you didn't see anything, the ultrasound, what would CT show? And if you're thinking of a drain, and then if you're finding a small one, that also may not be draining. So the rationale of going for that higher investigations, you need to have in your mind what did you have in your mind? Was it from a diagnostic point of view, or was it from a therapeutic point of view? And if you're not picking up the collections in ultrasound, must be too small even for you to see in the sequence as well. As you were saying, maybe worth waiting for the report to come. Only hint was that the patient was symptomatic for almost 2 weeks, so that's a little longer than unless you are thinking of an atypical communicable pneumonia. Otherwise, you will start thinking about primary etiology in that patients, except the total counts was high. So that was the only other thing. Fever, cough persisting with the total counts being high. There was possibilities of thinking of acute bacterial pneumonia. It is just because the duration was a little longer, we were so considered to be a possibility. Maybe waiting for those basic investigations to happen. Investigations. What's the socioeconomic background of it? Tell us about the background. Given us a statistician on the first slide, I have this of the TB pregnancy. It's social disease. Where is she from?
No, sir.